Excited to welcome everyone to our July Let's Talk Menopause talk featuring the incredible Dr. Emily Jacobs on brain health and menopause. So I have a quick introduction and a couple housekeeping items that I'd love to get off at the top, and then we'll dive into what I'm sure is going to be an incredible conversation. First of all, welcome to Let's Talk Menopause and our monthly menopause talk series. Let's Talk Menopause is a national nonprofit changing the conversation on menopause to ensure women get the information they need and the healthcare they deserve in midlife and beyond. I'm Alessandra Henderson. I am the Senior Program Advisor to Let's Talk Menopause, and I'm thrilled to be working with this incredible team to spread education and awareness. These monthly menopause talks are central to education efforts to ensure women receive evidence-based information from leading experts. If you like what you hear today, we do have over 30, edging even closer to 40 past talks on our websites with many of the leading experts. So we do encourage you to check that out. A reminder that all menopause talks are intended for informational purposes only, not as a substitute for professional medical advice, diagnosis, or treatment. And a huge thanks to Bayer for making these menopause talks available and sponsoring them. Again, a couple more housekeeping items before introducing Dr. Jacobs. One, we have, as Donna mentioned, we have disabled chat, and we'll only be using it to provide relevant links. We ask that you ask any questions that you have in the Slido app, which should appear in your Zoom. So you should see a prompt to invite you to participate. We will do our best to answer your questions, but we really appreciate your patience if we don't get to yours. And we're always flooded. There's always so many questions, as we know. But we'll do our best to address them either throughout the talk or directly from my colleague Donna, who might be responding directly. And please remember that we can't answer unique medical questions. So please try to keep your questions at least broad or broadly applicable as to kind of unique dosage or prescription information. Last but not least, we will be sending out a recording of this event. So if you're furiously taking notes or know someone who might be interested, we'll be sending out a recording. Okay, diving in. So I'm thrilled to introduce Dr. Emily Jacobs, who is a PhD in neuroscience and women's brain health expert, who currently serves as the director of the Ann S. Bowers Women's Brain Health Initiative, and is a professor of psychological and brain science at UC Santa Barbara. Previously, she's held faculty appointments at Harvard Medical School and Brigham and Women's Hospital. Her accomplishments include pioneering the use of precision imaging methods to generate the first detailed map of the human brain across pregnancy. That's amazing. As well as directing a multi-center study of the neurological changes that occur across the menopausal transition. Beyond her work at UC Santa Barbara, she holds a range of incredible appointments across the field, from the steering committee of the Women's Brain Health Coalition to the WAM Research Collaborative. Last but most certainly not least, she's joined former President Biden and Dr. Jill Biden at the launch of the White House Initiative of Women's Health Research. And her work has been featured in the New York Times, National Geographic, Scientific American, NPR, Netflix. The list goes on. Very, very impressive. And so thrilled to have you here. With that, I know I listed some of your accomplishments, but I'd really love if you could introduce yourself a bit, your unique background, and maybe just what's led you, the path that led you to studying women's brain health.
Yeah. First of all, thank you so much, Donna and Alessandra and the whole team at Let's Talk Menopause for having me here. I am absolutely elated. I think that the sort of science communication and education and empowerment that you guys are doing around menopause is just unmatched and so urgently needed. So keep it up. This is an incredible resource. And thank you all for joining in this webinar. It's really what a way to kind of cruise out the end of July. So I wear many hats. I run a research group at UC Santa Barbara, and then I also I'm a director of this Ann S. Bowers Women's Brain Health Initiative. We are a research center headquartered at UCSB, but actually oversee research activities spanning 7 University of California campuses, as well as Stanford and Cornell. And this, in the lab, we do really focused studies, but in the WBHI, it's all about taking women's brain health prime time. We think we can do that by harnessing the combined power of the University of California system. So, I think maybe we'll get into this later, but I think now is a really exciting time for women's brain health. It is historically deeply underfunded, deeply understudied, and I am brazenly optimistic that the best days are to come in terms of discovery and advancements in our knowledge that can lead to new treatments for everyone. Um, so how did I get here? I'll keep it brief. As academics, we love to talk about our journeys. I fell in love with neuroscience pretty early on in college at Smith. And then that was in the early aughts. It was when MRI, or these brain imaging tools, were kind of entering their heyday. It gave scientists this unprecedented access to the living human brain. Think about it. We, like with MRI, we suddenly have this way to understand how the brain works when it's healthy, or to understand what goes wrong when it's not. And that was all happening kind of in the late 90s and early 2000s when I graduated. I said I wanted to make a beeline to really some of the most innovative and sort of founders of the brain imaging field at that time. And it happened to be that many of those were at Berkeley. So I went to Berkeley for my PhD. And, I did what every young grad student does, which is, think like, what do I want to do for the next 5 years? What do I want to devote my life to? And always in the back of my mind, I really carried the sort of great feminist traditions of Smith with me, and thought, how could I apply these questions, this tool, this area of study in a way that improves the lives of women? And so that was sort of the sort of intellectual soup I was stewing in, I guess. And then, a series of fortunate events happened, and I came across a research topic studying really the role of estrogen and its ability to change neurochemistry in the brain, change dopamine function in the brain. And the second I got a taste for that, and I realized how powerful the data was, and how like nobody was talking about this at the human cognitive neuroscience level, I realized this was a gap that needed to be filled, and I was equipped to fill it. And I devoted, here I am 20 years later, still chipping away.
Well, thank you for that, and thank you for dedicating your life to it. We can dive in, and I think at the top of this, and please correct me if I'm wrong, but there is so much that we don't know. And so I think setting a bit of the stage here, and you will do this far more eloquently than I, but it's important to just say out loud how much we don't know here. So I know there are a lot of questions that I'm sure we're going to be looking for answers or looking for solutions. But you, as you said, have dedicated your life to it, and so excited to dive into that. Maybe if we could start with just that science, right? How, and specifically, how do fluctuating hormones during perimenopause and menopause affect the brain?
Yeah, and
Big question.
yeah. I'll piggyback on something that you say just to sort of set the stage, but obviously the purpose
Yeah.
of this webinar is to educate what we do know. But, as I like to say, there's so much about the neurobiology of menopause that we don't understand yet. And it's not because women are too complicated. It's not because menopause is like the Gordian knot of biology. It really is a byproduct of the fact that we have underinvested in women's health for so long. That's about to change. That is changing now, and we can talk about some initiatives that will ensure that success. But we do know some stuff. We certainly know a lot about neuroendocrinology. So when you say, how do fluctuating hormones during the menopausal transition affect the brain, let me just give like a 30-second primer on neuroendocrinology. So let me wear my
Take it away. I follow your lead.
Okay. So remember that the brain is an endocrine organ. And what do I mean by that? I mean that it guides the production of hormones from peripheral endocrine glands, including your ovaries. It contains receptors that respond to many of those hormones, like estrogen and progesterone. And actually, the brain, this is kind of like the nerdy part, but it contains all of the molecular machinery it needs to produce its own hormones from scratch. So when we talk about sort of perimenopause and menopause, let's think actually a little bit earlier during your reproductive stage, when you have a steady menstrual cycle, or maybe you're on a hormonal contraceptive. But during the menstrual cycle, that signal to sort of kickstart the cycle originates from your brain, an area called your hypothalamus, and it signals to the ovaries to to sort of release an egg that was going to like start that whole 28-day on average journey. And it's this like beautiful feedback loop where the hormones produced by your ovaries then feed back to your brain and say, okay, we've done with the cycle, and then the brain starts it over again. Now, what happens during perimenopause? Basically, the brain is trying to kickstart that signal through various hormones from hypothalamus and the pituitary, but the ovaries have nothing to give, right? Your ovarian follicle count might have reduced to the point where it's being stimulated, but there's no egg to be released, so there's no estrogen being produced. And the brain's like, wait a minute, I need the estrogen signal. So it sort of goes into overdrive and it's trying to push even further. And that's where you start to get these really wild swings in hormones where some months you might have a cycle, you might go 3 months without a cycle. And it's that sort of turbulence, if you will, that really leads to the kind of cognitive symptoms that we see. So, for a woman who's going to experience mood and cognitive symptoms, they tend to begin during perimenopause as those cycles are either irregular, cycles are skipped. So during the biggest period of endocrine fluctuations, and because the brain doesn't love that. And some women coast through those waves just fine, others don't.
Okay. And so I was going to ask you, what role specifically does estrogen play in supporting brain health, brain function, or cognition? I know you answered a little bit of that, but is there anything kind of specifically that we either know or are studying of the direct relation between estrogen and brain health and cognition?
Yeah, this is really my wheelhouse. So I'm a basic scientist. I'm in the lab trying to understand these like really sort of fine-grained mechanisms. And when it comes to estrogen and progesterone, there's this kind of focus on particular areas of the brain that we know have a lot of these receptors. So think of it like a ball and a mitt. The ball, in this case, is the hormone, and it's got to find the mitt to have an effect. But these receptors are all over the hippocampus, the frontal lobe. So that can give us insight into the kinds of cognitive functions that these hormones support, right? So we think about memory, we think about planning, executive functions. And as we sort of get into the conversation about the sorts of cognitive changes that happen during menopause, it's really governed by that basic neurobiology, like where are these hormones acting in the brain? And then what happens when the hormonal signal is not as sort of smooth or rhythmic as it once was.
Okay. And are there common symptoms that we should, there's the kind of like $1 billion question, which we're getting to right after this, is after we kind of established the science here. But of course, which is, how do you know when brain fog is normal, or an early sign of dementia and Alzheimer's? But we'd love if you could just briefly just before we get to that, some of the symptoms that we can or should be thinking about in perimenopause and menopause as we see these hormonal fluctuations. So what are the common symptoms to look out for?
Yeah, I mean, so symptoms across the board are probably well known to this group, but I'm going to focus on the ones that really sort of are affecting kind of what we call neurological functions, and that's sleep disturbances, mood changes, and of course, brain fog. And when we talk about brain fog, there tends to be very particular cognitive domains that are affected. It's not like across the board there are these global changes. It's actually pretty specific. And again, that has to do with the underlying neurobiology, like where are these hormones acting in the brain? And verbal learning and verbal memory are the big ones. About if you've got a grocery list and you have to memorize it, and then you go to the store and you have to recall it without forgetting anything because you're cooking dinner that night, or you go to a party and you meet a bunch of people and you have to remember their names, right? These are the things that tend to be the most kind of vulnerable across that perimenopausal transition. And again, those verbal memory changes start in early perimenopause, and they show a small but consistent decrease into the postmenopausal period. So, I think and that's using kind of objective lab measures. And so this is one thing to sort of note, is that for a person feeling cognitive symptoms, know that the assessments that we might track in lab or in the clinic often validate your lived experience, right? When you say my memory is shot, we can track that. But I want to offer kind of 2 points of reassurance there. These are almost always small changes. So even though they're like statistically significant, they tend to be very small, but persistent. And even with these sort of menopause related cognitive declines, the cognitive performance still remains within the normative range, right?
Mhm.
And then number two, this is really important. What I like to say, we have to benchmark our data. So we have to understand, like, how does this degree of kind of cognitive change compare to something else? And so here I
Mhm.
give my favorite example. With verbal memory, verbal learning, there's actually a well-documented female advantage. So women outperform men on verbal tasks. The sex difference starts around puberty, and
Mm.
then throughout life, you see this consistent females outperforming males, right? So when a woman then hits the perimenopausal window and you start to see this verbal learning and memory performance tick down a notch, she's actually just declining to the level of men. So it can't be that bad. It feels bad to us because we've like enjoyed this advantage all of our lives, but we are really truly just declining to the level of men. And now equity has been achieved, and we can all help each other remember those grocery lists a little bit better.
Yeah, the frustration is there. However, the knowledge that like have held a superior advantage is something to carry in our back pocket.
It's the sting out of it a little bit.
Yeah. Yeah. Well, maybe answering that because there are several questions here. And it is what you've defined this a bit, but what is brain fog? And then maybe if you could also kind of what is dementia and Alzheimer's and how do we kind of distinguish between the two? There are just general questions around obviously cognition at this phase.
Yeah, so let's disambiguate the two. So first of
Yeah.
all, about 50% of women will experience cognitive symptoms through menopause, and
Mm.
about 70% of women will experience some kind of neurological symptom. And that's a very broad term. That includes cognitive changes, irritability, insomnia. So know that you are not alone. This is an experience that most women will go through. Um, so let me tell an anecdote. There was this amazing woman, Rebecca Bauer Kay, and she's actually a congresswoman from California, representing a northern district. And she has this very, kind of high powered job. She's at the California legislature. And a couple years ago, she went to her doctor and said, something's not right. I am experiencing intense brain fog. Like, I'm really worried. Is this dementia? And she bounced around to sort of three or four doctors who sort of didn't know what to tell her. And finally, and we can sort of get to why it takes so long to get that accurate diagnosis, but finally they realized this is menopause brain fog. It's not dementia. But she was so worried about this. And it wasn't until she then started menopausal hormone therapy and symptoms were relieved that she realized that it was transient. It was not a harbinger of something more severe. So now let's differentiate those two, right? On the one hand, we have these sort of transient menopause brain fog. On the other hand, we have dementia. These are two separate phenomenon. Um, Menopause is a universal experience. So for any woman who lives past the age of, say, 55, all women will experience menopause, but most women will not go on to develop dementia. It's really important to remember that. So
Yeah.
menopause is not a disease, it's not a disorder. Most women will go through it and not develop dementia. There's actually about a 20% lifetime risk of Alzheimer's disease in women, meaning 80% of women, right, will never experience it.
Mhm.
So unless you have a family history of early onset Alzheimer's
Mhm.
disease, then dementia at midlife, so those cognitive changes that are happening at midlife being dementia, very rare. So the vast majority of women, these transient cognitive
Really
problems.
important to double down because we get this question all the time. So I appreciate you bringing this up. Yeah.
Yeah. So these transient cognitive changes during perimenopause and postmenopause is really not going to be a sign of anything more serious. It's very reassuring,
Yeah.
which doesn't mean that those are not affecting your life. They are, and we could talk about options, but it's not something that you have to worry about in terms of long term. Okay, so you ask, what is brain fog? That's not actually a clinical term. There's no official definition, but it really just refers to a set of cognitive symptoms. This is forgetfulness, trouble focusing,
Mhm.
trouble paying attention, fogginess, losing your brain of thought, the sort of tip of the tongue phenomenon, word finding difficulties. So brain fog is common in menopause, but it's not exclusive to menopause. We know that there's other transient conditions. If your blood sugar levels are off, or if you've had a viral illness or chemotherapy, all of these can lead to transient states
Mhm.
of brain fog. I will say scientists do not have a great grasp on the kind of neurological basis of brain fog, but we're getting closer. We think it might have to do with sort of an immune response in the brain, and the
Mhm.
cognitive consequences are really kind of a result of your immune system, affecting brain function that tends to clear once the virus is passed, or once, in this case,
Yeah.
levels stabilize.
Yeah. Are there, because we'll talk about hormone therapy too, because we know, especially as we're talking through treatments, but really quickly, because there are questions, whether you have a family history or not, are there cognitive assessments that women can either do at home or that they should be talking about with their provider to understand and either set a baseline or understand where they are?
Yeah, I mean, if you are worried about dementia, testing for dementia involves like a whole set of evaluations. So there's no
Okay.
single test. But if this is something that you're worried about, first of all, go to your primary care physician and talk to them, and they'll do a basic evaluation. They'll do a physical exam. They'll take medical history. If they feel like this is sort of outside the realm of what might be expected with menopause, then they might kick it up to a team that does an actual neurological exam, performs cognitive tests, in some cases performs brain imaging or blood tests. So with
Hmm.
brain imaging, they're really going to be looking for other causes that are known to impair memory. So whether that's a sign of a stroke or a tumor, traumatic brain injury, like did you have a recent concussion, maybe even undiagnosed concussion? Do you have fluid in your brain? So other sources that could lead to brain fog. There are other imaging tools that can actually determine if a person has high levels of beta amyloid in their brain. This is a marker of Alzheimer's disease. So this would be really sort of a set of kind of clinical tools that would be used to accurately diagnose you. I would say for the vast majority of women, you would never get to those endpoints. It would
Yep.
really.
Okay. And let's, if we can talk a little bit about menopause hormone therapy, or HRT as it's commonly known, and what we can do about it. So, or maybe I'll maybe start with menopause hormone therapy, but what can we do about brain fog?
Yeah. So menopausal hormone therapy is really the gold standard treatment for moderate to severe hot flashes and vasomotor symptoms. So it is not, we follow the Menopause Society guidelines. Menopausal hormone therapy is not considered a first line defense for brain fog itself. However, we know that for a woman that has moderate to severe vasomotor symptoms, especially at night, that leads to disrupted sleep or insomnia, that then can be a cause of cognitive symptoms. So, in that case, treating the symptoms, which are really the hot flashes at night that keep you up, can have these knock on effects for improving cognition. Um, I think hormone therapy would really be a good candidate in that case. This is really kind of based on the work of Pauline Mackey, Rebecca Thurston. They're doing fantastic work, and they have shown that women with more frequent hot flashes, particularly at night, have poor memory performance. So
Mm.
the question and the brain circuitry that supports memory performance is altered. And Dr. Mackey actually has some initial evidence that treating vasomotor symptoms can improve memory function. And we really need sort of support to run larger randomized controlled trials of this, but I would say the early evidence is pretty promising. So you treat the symptoms, and if you're having those hot flashes and vasomotor symptoms, you can improve brain health.
That's great. And I was going to say, because the most popular, I know, as I'm tracking this, I'm seeing some of the comments and questions that are coming through, and the most popular or upvoted one was, how do I know if it's my hormonal fluctuations or lack of sleep that's causing memory loss, right? And it feels like this soupy mess of,
Well,
to distinguish.
yeah, that's an interesting question. And actually, Dr. Mackey has done some work, so we can get into different forms of treatment. So we mentioned menopausal hormone therapy. That tends to be an estradiol, and if you have a uterus, that's paired with a progesterone to protect your uterine lining. And that can be taken as a pill, a patch, a cream. That's really sort of where the menopausal hormone therapy comes into play, because these are hormones. But there are non-hormonal treatments that have hit the market. Not to nerd out too much, but these act on your brain, on the brain's thermoregulatory circuit. So again, just like your brain controls the hormone production, your brain actually, hot flashes like originate in your brain. It's a signal from your brain to sort of cool the periphery. And because estrogen is no longer hitting the brain, those wires get all crossed. So there's a drug that can act on that circuit to kind of quiet those neurons down. It's non-hormonal. So this, the idea is that it could be more effective for women that have contraindications and cannot take hormone therapy. And what Dr. Mackey found is that treating hot flashes with this non-hormonal therapy actually improved cognitive function, meaning that actually it wasn't the hormones themselves, it was just eliminating the hot flashes. There's a lot more research that should be done in that space, but I think it's promising.
Is this Astellas's Veoza that she was working off of, or is there another?
A derivative, yeah.
Okay.
Yeah.
Okay. And we can do a little bit more research to kind of follow up on that study. But yeah, it's again, that correlation, there's more work to be done to identify the root cause. Sorry, go ahead.
Well, I was just going to add one thing, because the question then becomes, well, what about women who don't have moderate to severe hot flashes? Like, what, but they are still experiencing brain fog. Like, what of them? And I would say that here the evidence is neutral. So for women that do not have these hot flashes, there's no evidence that menopausal hormone therapy will either help or hurt cognition, right? So I'd say it is important to note that menopausal hormone therapy is not prescribed as a preventative tool against dementia. There's really kind of no consistent evidence for that, but there's no consistent evidence that it will hurt you either.
And I see some questions here on, and there are always questions, we get this every talk of, I'm over 60, can I start it? Or when do I start? There might be, we can't answer probably every single one there, but is there a recommendation that you, understanding you're on the research side of things, but generally speaking, whether perimenopause or menopause, are there recommendations of when to get started with some of these potential treatments?
Yeah, so it tends to be, within 5 years of the menopausal transition or before the age of 60,
Okay.
it's a good window to start. So what we think of like kind of this window of opportunity where treatment has the sort of risk to benefit ratio is in the person's favor. Starting outside of that window, that risk benefit ratio tends to switch a little bit. And I would just make a plug for people to go on mymenoplan.org. It's a fabulous resource. It's all evidence-based medicine. You can select the variety of symptoms that you have and put in sort of very basic age and demographic information, and then it will give you a set of treatments that could be things that you could be interested in. The whole idea is that you can kind of print it out and take it to your doctor and use that as a basis for discussion at your next
Because there was a question here, and again, I'm not calling it out specifically, but we get this every, most of our talks here of my primary care doctor or my doctor doesn't want to prescribe hormone therapy. And yet I hear in these talks that it is, could address my symptoms. And so just calling that out, that women kind of across the country and around the world, but across the country are experiencing that. And the more that you can come in with your own research and evidence, and again, I know it creates a little bit more of an outsized burden on women to have to maybe advocate and do their own research to get the medicine and care that we deserve. But if you do feel like your provider is not, you are interested and you feel and you are not contraindicated, or your family history means, that you are a candidate, that you can advocate, as well as, and I'll plug for us to include in there, if you're looking for a new provider, at Let's Talk Menopause, we have how to find a provider and how to prepare to talk to your provider. We have that resource available to you as well. And again, it's education, and being armed with your own information is the best way to get the care you deserve. If we could actually have one quick question more because I want to switch a little bit to kind of cognitive function, but there was a quick question actually about testosterone and on the impact of, is there a known impact of testosterone on the brain? And maybe I'll expand that to beyond estrogen and progesterone. Are there any other hormones that we could or should be looking at or studying?
From a basic science perspective, meaning in the lab, yes, testosterone is neuroactive, so is cortisol. These are all in the same family of
Mhm.
steroid hormones, so their chemical backbone looks very similar. And these are all, we know, androgens and estrogens, these are all um, influencing aspects of brain structure function. What that means clinically and how we could kind of use that basic science to, to sort of translate that into medications or pharmacology, we are definitely not there yet with testosterone or with other hormones. I'd say we're
Okay.
still waiting for that science to bubble up the level of treatment.
Yeah, the always infuriating yet truthful answer of
Yeah,
we have a lot more work to do.
stay
Um,
tuned.
which speaking of, and a question that we are hearing from our community and that comes up, as we talk about cognitive issues, it feels like there's a conversation around how hormones in midlife impact either the diagnosis of or the onset of ADHD. And I use that as the bucket term for just, focus, attention deficit disorders or the like. As much as you can at least share what you have heard or seen is being talked about in this realm.
Yeah, so I'll point to the fabulous work of Dr. Neil Epperson.
Mm,
Her work really tells us that some women will experience new onset ADHD-like symptoms as they transition through perimenopause and menopause. And this is likely due to the declining levels of estrogen because that leads to a concomitant decline in dopamine, this critical neuromodulator that sort of underlies ADHD symptoms. Now, for women with a previous history of ADHD diagnosis, these symptoms can get worse during perimenopause and menopause. So it's definitely this like inflection point that can bring on these executive dysfunctions that share all of the hallmarks with ADHD.
yeah. Well, I appreciate it. And again, there's limited research. I've also learned a new word, concomitant.
Oh.
You're gonna have to
Yeah, yeah, yeah. Yeah, I would say, again, with the cognitive domain, it's the by far the most common and consistent
hmm
reports are within verbal learning
Yep.
memory, but these sort of executive functions, planning, working memory, which is sort of the ability to keep information in mind over short periods of time, those are executive functions, and a smaller subset of women will experience those changes,
hmm
probably tied to this estrogen dopamine link.
Okay. Do we, as far as we know, is this the new normal in terms of, how do we address this? Is this the temporary during the transition or is this the new normal? And how, yeah,
Yeah, again, so I'd say no, not necessarily. We know that, again, in a sort of experimental setting, this is not necessarily reaching the level of
yeah.
clinical standards yet, but we know that menopausal hormone therapy might actually be really great for alleviating some of those symptoms. And there's evidence from a randomized control trial that suggests that psychostimulants are effective at reducing both self-reported ADHD symptoms and objective, like in the clinic, in the lab, measures of cognitive performance in women who are going through menopause with new onset executive dysfunctions. So there are options.
Okay.
Although I'd say we really need more randomized control trials, but there
Yeah.
are options to explore.
Yeah. Um, well, so I'm curious, I know we've talked a lot about menopause hormone therapy, but I would love to talk about, expand a bit on both the general prevention and protection strategies. Maybe we could talk a little bit about beyond the pharmacological options. What are some of the evidence-based lifestyle changes or things that women can or do or be thinking about from a long-term prevention and protection strategy?
Yeah, I mean, it's all the stuff your mama told you, right? It's exercise, it's prioritizing sleep. I know that that's not like the answer, but I'd say that the good news is that these are behavioral modifications that are going like whether or not you're experiencing menopausal brain fog or cognitive symptoms, these are going to have positive effects. There's
Mhm.
actually just some announcement. So last week was the big Alzheimer's meeting in Chicago, and there was the results of a clinical trial testing many of these behavioral modifications on cognitive scores early in dementia, finding beneficial effects. So regardless of kind of, you know, who's being who's adopting these, they're good ideas. So, you
Yeah.
know, take the walk and, you know, have a plant forward diet. Just do it. And it's never too late. That's the other thing. Like, I think people thought, well, I've lived my life in this one way. It's what hope is there for me yet? And I would say it is never too late to prioritize your brain health. You can get started today.
Okay. Always a little bit of a hesitate to say polarizing, but can we talk a little bit about either, supplements? I think a lot of people are getting sold things right now, especially, is there any research or data around supplements or things that we should be considering incorporating as well around brain health, and cognitive function?
Yeah, I think, you know, it's incredible that menopause is in the spotlight in a major way. Really kind of for the first time in our lifetimes, right? The last few years has seen everybody suddenly talk about menopause and like how awesome is that. The flip side of that coin is that of course there's fear and there's anxiety, and whenever there's fear and anxiety, that can be capitalized on by the wellness industry in ways that are really not helping women but sort of helping the person.
Yeah.
So, you know, I will just say, you know, we want to use evidence-based medicine to
Mhm.
guide all of our kind of clinical decision making. So go to the Menopause Society website. There's resources for patients. You know, I know Let's Talk Menopause has this. Menopause Society
Yeah.
also has a like find a provider within your zip code that is a
Mhm.
certified menopause specialist. Go there. They will know all of these options, including kind of holistic medicine, but they will be coming at it from a kind of evidence-based perspective.
Okay. Yeah. It's funny. I feel like even before the menopause kind of movement had caught the mainstream, you always read about omega-3s or adaptogens or certain things that you can be doing. And to your point, I know so much of it is, eat well, exercise, um, try management of symptoms around that could be impacting your brain health and cognition. So sleep
I
and
mean, if you're worried about it, like you can, like vitamin deficiencies will for sure lead to symptoms
Mm.
that may look a lot like menopausal hormone therapy. I mean, B12 deficiencies, thyroid deficiencies. So you can get panels, you know, for those basic tests drawn at your annual visit. But, you know, if those levels look good, you don't have to continue to supplement. You're like, your body's really good at absorbing everything it needs as long as you have a balanced diet.
Okay. That's helpful. And you mentioned also finding a provider. And so we oftentimes get this question too of like, what should my care team look like? I'm not, leaving out all of the broader menopause symptoms here, but just can you define, outside of having either a PCP or a your general practitioner, are there certain doctors, or clinicians or experts that women should have and start building relationships early, um,
Yeah.
to
And
track?
this is again where I would go to somebody who is a certified menopause specialist. So somebody who's, you know, getting continuing medical education in menopause, going to the annual Menopause Society conference or the International Menopause Society conference
Mhm.
to make sure that they're staying abreast of like the latest science in this space. That's who I would look for. And again, there's resources
Okay.
online for you to find those providers. And maybe just like one point is that what people don't realize is that in the United States, only about 20% of medical schools, this is based on a Johns Hopkins survey from a few years ago, but only about 20% of medical schools actually include menopause in their basic science curriculum.
Mhm.
And for those that do, it's mostly an elective. So, like, if you need the bumper sticker, here it is. Like, women's bodies are not an elective. And
Yeah.
what that means is that most doctors practicing today have not had formal training in this. Um, So seek out those that do. Otherwise, you're going to be met with the sort of proverbial shrug. You're going to be bounced around from doctor to doctor through no fault of their own. It's just that they have not received this training. I will say, encouragingly, there are efforts underway from a policy perspective to change this. One that I am thrilled about is a bill working its way through the California legislature called AB 432. It's the Menopause Care Equity Act. And if Governor Newsom signs it into law, it would ensure CME credits are taken by any provider if 25% of their patient base is adult women, which means anytime you go to the doctor's office, they will have basic knowledge to serve you. And it would require insurance coverage of menopausal treatments. So these are the sorts of things we need to be advocating for as women, so that all of these very real symptoms are not only understood, but addressed.
Yeah.
And
we have just to continue and to double down on that, because, how can everyone take the 20 seconds to do kind of their part to speak up and out? If you go to Let's Talk Menopause, we have two kind of campaigns and advocacy efforts. One is around unboxing menopause, so very different, which is around local vaginal estrogen or local estrogen. Very different from this conversation, but we have been collecting close to 20,000 signatures to send to the FDA, because that discussion is ongoing currently with the FDA. We're in active discussions, but also we've been tracking on a state-by-state basis. I think it's a third of states today, as you mentioned, are either in the process of discussing or enacting menopause new laws and legislations, which should have been there all along, but we're making up for lost time. Well, I'd love to kind of hear a little bit more about your research. We've talked a little bit about what the state of the world is today, but if you could tell us a little bit about your work and what might be some exciting things that are coming out in the field, would love to hear a little bit about that, and then we'll do some rapid fire questions from the audience.
Sure. Well, we've talked a lot about menopause. My team is really interested in another major endocrine transition state, which is pregnancy. So we use what's called precision imaging. So the idea is that we can take MRIs with really high time frequencies. We can follow women really carefully over these endocrine transitions to understand how the brain changes. And I think you alluded to this in the beginning, but in 2024, my team published the first map of the human brain across pregnancy, revealing this really incredible metamorphosis that we can see unfold really week by week across pregnancy into the postpartum period. This is a highly dynamic period for the brain, and it's revealing levels of neuroplasticity that neuroscientists really didn't understand was possible in the adult human brain. We knew that during adolescence, the brain undergoes all this sort of protracted neuroplasticity. But here we are showing that a woman in her 20s, 30s, 40s is capable of really the same magnitude of neuroplasticity driven by this surge of hormones. I think that's so cool from just a basic science perspective. It also suggests that there's clinical knowledge to be gleaned there. Like, imagine if we could understand the drivers of that, and we could apply that to cases where you really want to kind of encourage neuroplasticity, like in cases of traumatic brain injury or stroke. And I just think this is such a powerful story of how women have been understudied and, kind of ignored so long in the history of the biomedical sciences. Most animal research is conducted in males. Women were excluded from clinical trials, before the 1993 NIH Revitalization Act. And then even in my field of brain imaging, there's about 50,000 neuroimaging articles that have ever been published on the human brain. But of those, less than half of 1% cover health factors specific to women. Half of 1%. This is a kind of in a Nature article that I published a couple years ago. So that's everything we know about how the brain responds to menopause, pregnancy, hormone therapy,
Infuriating.
everything. So, and I think why this paper that we published last year got so much press and so much attention is that it's just an example of, like, think of all the little nuggets of gold, all of the wisdom lying just under the surface of our knowledge that we could unearth if we just pay attention to women, if we just study women.
There was a question actually from the audience of, do you see that trend changing? Are you starting to see that? I know you within your university or, your ecosystem you have, but how are you seeing that?
Yeah, I mean, I was at the annual meeting of Organization for Human Brain Mapping. So this is where like all the human imagers around the world converge in one space. And, 3 or 4 years ago, these were very niche topics, and now it's exploded. You see just these like huge subgroups that are all, early career trainees who have this amazing hammer. Maybe they're like whiz kids in computational AI, whatever, but they want the nail. And for a lot of them, the nail is women's health. Like, how do we take this, tiny little speck of dust and make it our entire universe? So I think it's a totally exciting time for this. You're going to see a lot of advancements at a much faster clip in the next decade. I'm really brazenly optimistic about that.
I am too. I will say I got off a call this morning with a woman who kind of heads up innovation and clinical partnerships at a major health plan. And she's been a long time women's health advocate. And so she was starting to talking about some of the platforms that she's working with. She's having everyone actually start to divide their reporting data by men and women, understanding that different solutions are going to impact differently. And so it's just starting to have these advocates in place. We have many miles to go, and data and research takes time. But how seeing these glimmers of hope around understanding the impact of different solutions on women, both in the early stages all the way through to in market, gives me high optimism.
Yeah.
So before we transition to some of the rapid fire questions from the audience, anything else on what you were doing or studies in the field that we can or should be paying attention to, or should we transition over?
I mean, I can make one more I can share one more story. I think in addition to the sort of precision imaging, which is really kind of transforming the neuroscience field, we can also apply big data. And I think
Mm,
application of big data for women's brain health is like where a lot of the discoveries are going to come from. Um, Big data is not new. Like if you think about revolutions in genomics, particle physics, astrophysics, right? It's major breakthroughs have come from groups of people pooling data, pooling talent, pooling resources, and amassing data sets that nobody thought was possible.
yeah.
We can do the same for neuroscience. We can do the same for women's brain health. And that's really the motivation behind our Anna Spowers Women's Brain Health Initiative. It's to take women's brain health prime time. And again, how we're starting that is by thinking about the University of California system. We have 10 campuses spread out across a geographically and demographically diverse state. We're now the fourth largest economy in the world. We represent 12% of the US population. And we have all of these University of California systems which with world-class brain imaging centers. So what we've done is basically just create a pipeline for these centers to pool data and to add critical missing questions about women's reproductive health so that we have this sort of like a data science incubator where research questions can be seeded, ideas can be seeded, and discoveries can be made.
Yeah, that's amazing. Well, I'm optimistic. Okay, so quickly, for maybe the next five or a few, we'll have some questions here. At the top is, can you discuss the stress on brain for women who are in menopause while caring for children and elderly parents? That might be a little bit beyond what would love to just hear about the impact of stress on the brain.
Yes. Yes. So we know that chronic stress is, you know, um, not helpful for brain health. There's models of kind of caregiving stress that have been really studied from
Mm,
how caregiving stress can make you age faster, whether we're looking at kind of what are called epigenetic clocks in your blood or telomere shortening or even accelerated brain aging. In some cases, that can be reversible once the stress is mitigated. But to combine chronic stressive caregiving with the menopausal transition is a really important area of study. And, I think this is where there are like specific recommendations I could give to a woman, but I also think we need to zoom the aperture of our lens out and think as a society, how do we support caregivers who have maybe
yeah.
elderly parents or young children? Like there needs to be more investment in resources across the board to take those stressors away.
Oh my gosh. Preach. I want to take that clip. I couldn't agree more. Have there been studies about how hormone therapy interacts with antidepressants or SSRIs?
It's coming. I don't know that literature super well, but I would say I can think of the folks that I would follow. Again, Rebecca Thurston, Pauline Mackey, Neil Epperson, and Hadeen Jaffe come to mind about sort of the interactions of those things. But usually, from a clinician standpoint, they like to start simple. So it's like start with one and see if, say, an SSRI mediates the symptoms that you were concerned about. If it doesn't, maybe you scale that back and do menopausal hormone therapy. I think what we wouldn't want to see is like a whole bunch of stacking. You'd really want to figure out like what is the right clinical course of treatment that can address those specific symptoms without just piling everything on all at once.
Starting at the same time.
Mhm.
Very quickly, because we get this question a lot, and but if you are 10 years past menopause, and you were never offered it, or you'd want to start menopause hormone therapy, can you, like, what is that 10-year mark? And then also, can you ever get off hormone therapy?
Can you ever get off? Um,
And we do have talks that go into great detail here. So
Yeah, I
just
would
very
point them
briefly
to,
addressing.
I would
Yeah.
probably point them to those talks, but I would say this is where you have a conversation with the provider. I would ask, first of all, why do you want to get on? What is it that what symptom are you trying to address? If you do not have a symptom, there's no sense to get on it after 10 years. But if there's specific symptoms, what are they? When did they emerge? And could menopausal hormone therapy be a good option for you even later in the transition? And it's not like a blanket no, but I would say you'd really have to be careful about weighing those risk to benefit profiles.
Yeah. Okay. There are a couple of questions kind of bringing them together a bit of if you go through surgical menopause or medical menopause, right? Because you're on certain prescriptions or medications, is there anything that cohort of women should be thinking about and its impact on cognition, since it's typically sudden and immediate?
Super sudden, yeah. In most cases, if you do not have a contraindication, you will almost always these days be offered menopausal hormone therapy just as the sort of assumed course of action. I mean, you'll leave the OR with a patch on you at this point. Um, there are smaller subsets of women for whom that isn't an option, but for the vast majority of women, yeah, with surgical or ovarian or sort of pharmacologically induced menopause, you'll want to have that replacement.
Yeah.
As
Okay.
yeah, I mean, the menopausal symptoms can be so immediate.
Yeah. Yeah. It's really one day you're in, one day you're out. It's pretty sudden. Are there any activities that help with brain cognition, like puzzles or reading? I know Sudoku always oftentimes gets brought up, but any
Yeah.
other things that we can incorporate into our routine?
I think the biggest one that sometimes gets missed is just how cognitively demanding it is to be a social animal, right? We are social animals.
Mm,
We are, around other people, and it takes actually a lot of intricate cognitive and emotional sort of deftness and nuance to be in social settings. So I would say, yes, do your puzzle, but do it with three friends while you're talking and catching up on life and reading social cues and using theory of mind. So, um, you know, traveling, putting yourself in new positions is also great for the brain. Learning
yeah.
a new language, learning piano, taking up a new hobby. I would say doing rote activities, like if you're doing the same Sudoku puzzle or same crossword puzzle, your brain tends to kind of get used to that new normal. I'd say mix it up a little bit. Try something different that encourages you to like when it's uncomfortable. That's when you know your brain is working.
Ah, that's great. Well, I know kind of transitioning or switching gears a little bit, I would love, it's where we head towards the top of the hour here. We always try to end with, we've learned so much, right? We've covered a lot here across just the multitudes and how much we know, how much we don't know, and the various ways that hormones and the menopause transition impact a woman's brain health. But, it's always ending on a call to action of what can we do? What are, in your mind, what are the top 3 actions a woman can take today to start either protecting and strengthening her brain, or to just, yeah, to start focusing on brain health? Because it's kind of the last thing that you think about until all of a sudden there's a problem. But what are your recommendations to focus on brain health and really give it the attention that it deserves?
I would start with, if you are in perimenopause, menopause, or early postmenopause, and you are experiencing moderate to severe hot flashes, treat them, right? There are good options for you, and doing so is probably going to improve your overall brain health. Both what you feel, like your subjective, but also what's going on under the hood is going to be very grateful. Again, this stems from the work of neuroscientists showing that those hot flashes, it's just, they're not great for the brain, whether you feel them or not. So you can treat them. We have good symptoms. You do not need to suffer in silence. So speak up. You don't get a badge of honor for like making it through menopause and being miserable and suffering. So treat the hot flashes. Another one we haven't really talked about, but I would say heart health is tied to brain health. So take care of your heart, and then your brain's going to thank you for it later.
Yeah.
And, I think this is kind of going back to the hot flashes, but really figuring out a way to prioritize sleep. And I realize that can be very rich for women who are in the thick of their lives. Maybe if they're having a career, they're in the thick of that, or they've got young kids, but be unapologetic about prioritizing your sleep.
Mhm.
Like, often that can be sort of like the link that puts everything else in place.
Yeah. Well, very wise words. We're so grateful to have you here. We've learned so much. I know there's a question on how we can follow your work, and so we might drop a link to it sounds like your clinic at UC Santa Barbara. But also please do, we're excited to see what you are doing to help further the menopause conversation. We're so appreciative of your time. I know we couldn't answer every question here, but we are so grateful to have you here. Thank you. If you need to drop, we're going to go through kind of the last little bits on our end, but learned so much and just excited to continue the conversation as the whole field moves forward. A couple of housekeeping final wrap up items. You will see that we have launched a survey on Slido. We absolutely love your feedback. It does inform our upcoming sessions. In fact, we have a talk. We're taking a break in August, so everyone can just enjoy themselves in the summer. But in September, on September 25th at 12 p.m. Eastern Standard Time, we are hosting Dr. Wen Shen for a Perimenopause 101. And then on October 16th, this just got confirmed today, we are doing a whole talk on sleep, actually, with Dr. Shelby Harris, who is an incredible resource. So understanding that, perimenopause, sleep, and getting into these topics are some of the biggest feedback that we hear from our community, of getting a better understanding on what it is and what we can do about it. So we hope you will join us for those, and keep an eye on your email as well as perhaps here to be able to sign up for future talk. But thank you so much to Dr. Emily Jacobs. We're really grateful for your time, and please do fill out the survey. We do incorporate your feedback, and we hope everyone has a wonderful Thursday.